Great, thank you very much. Okay, so suprachoroidal space has been been more and more used for different interventions. But just to give you a little update on the space. So this is the endoscopic view with the camera in the suprachoroidal space, and you can see that it's a space between sclera and the large choroidal vessels, which are traversed by the nerves and vessels traveling in that space. The space itself does not exist in the physiologic conditions, but in pathology it opens up. In the physiologic conditions, it's a tight tissue of hyaluronic atreus and matrix filled with occasional cells such as hyalurocytes, myofibroblasts, pigmented cells, and macrophages. And within that space, we've got major arcades of the nerves and arteries that travel at 3 and 9 o'clock, and also large vortex veins which exit at the 11, 1, 5, and 7 o'clock. These are the most common conditions. However, there are anatomic variations, and one may have up to 8 to 12 vortex vein exits. So with the intervention of the space, avoiding the horizontal meridia and when traveling posteriorly, being aware of the vortex vein is probably one of the major ways of preventing hemorrhagic complications. So why use suprachoroidal space? Well, there are several advantages. One of the big disadvantages of vitreous delivery is the induction of pressure and cataract. There's also, being immune privileged side, the vitreous is very vulnerable to induction of endophthalmitis if the organisms were present, whereas the suprachoroidal space is a lot more well vascularized. And also the target tissue, if the choroid itself is the target tissue or the outer retina, then it makes a lot more sense to deliver that and bypass the complications associated with the vitreous cavity. The downsides of using the suprachoroidal space is that being a highly vascularized structure, there's a very rapid washout time. Then there's a current of movement of fluid within the eyeball, which corresponds to pressure gradient. So the pressure within the vitreous cavity is 2 to 3 millimeters higher than it is in the suprachoroidal space, and then few millimeters higher than it is in the orbital space. So the normal current is UV vortex outflow and UV scleral outflow. And these two streams of fluid wash out the substance within the suprachoroidal space very rapidly. And because of that, this space is probably best designed for delivery of the slow release medication, and triamcinolone crystals are probably quite well designed, but Siggy will later on tell us about the use of slow release devices as well in the suprachoroidal space. And also the downside is the tissue being highly vascularized. It's prone to hemorrhagic complications if the vessels were damaged. So using sharp instruments is probably one of the major risks for inducing the problems. So in terms of delivery, there's been several steps in the development of the drug delivery systems. So the the oldest and conventional is the straightforward cut-down system and very careful separation of the sclera from the suprachoroidal space using viscoelastic of some sort, and then using blunt cannula. So there are on the market olive tip cannula, which are available in 23 and 25 gauge, which can be used for safe introduction of substance into the space. But they're also Clearside Biomedical have introduced sharp needles, which are used for delivery of the triamcinolone crystals in one device, and they come in two lengths, 900 and 1100 microns. So they suggest that one starts with 900 and puts the pressure, and if there's a resistance, then they move on to 1100 to overcome the distance. But again, this can be variable, and as we know, the highly myopic eyes have a lot thinner sclera compared to hypermetropic eyes, so there is certainly a degree of variation within that. So, and also there's more and more potential for exploring the subretinal gene therapy delivering via suprachoroidal approach. And benefit of that is obvious. With the transretinal subretinal gene delivery systems, there's a loss of vector and material into the vitreous cavity. And that regurgitation, first, it's a wastage of the very valuable medication, and second, it promotes the epiretinal proliferation. And if there's a way of avoiding that reflux back into vitreous cavity by approaching subretinal space through suprachoroidal space and puncturing it at the back, then that potentially can give a lot of benefits. And Alan Ho's group in the States is working on that currently, and it'll be exciting to see the results of their trials in the future. So in terms of the drug delivery, there's been a lot of interest and a lot of studies going back to 80s, and currently the main areas that were explored are the diabetic macular edema, occlusive vascular disease and macular edema, AMD, and uveitis with cystoid macular edema. Some of them are now on stage 3 with SAPPHIRE and TOPAZ study. However, they did not show, both studies were terminated without showing significant benefit from use of suprachoroidal corticosteroid in combination with anti-VEGF. The area where it found significant benefit was the uveitis, and that's not surprising because the target tissue is the choroid itself, and introducing the triamcinolone crystals into suprachoroidal space has been shown beneficial for the treatment of cystoid macular edema, and that's one of the major indications for clinical use at the moment. So we will later hear studies about the cancer implication for choroidal melanomas from Martina, and again, that also is beneficial because of the target tissue being in the choroid itself. So just to give you a very brief sort of summary, so Tanzanite study was carried out for retinal vein occlusion and did not show sufficient benefit, and therefore vein occlusion currently is not the ideal target. Diabetic macular edema, also the HALC and type B study have been carried out and did not quite show the benefit. And again, the issue with diabetes is the inner retina and its perfusion rather than the outer retina, and that is probably why the benefit is not being shown. In age-related macular degeneration, there's some early tyrosine kinase inhibitors and gene therapies that potentially will be quite exciting to watch in the future. And that takes us on to the use of suprachoroidal space for the treatment of retinal detachment. So we've been hearing quite a lot of very interesting discussions at the Euretina Congress this year about use of the different approaches in the management of retinal detachment, starting from the classic scleral buckle to different variations in vitrectomy technique to even an excellent debate on the use of pneumatic retinopexy for selected cases of retinal detachment. And I'm going to throw suprachoroidal buckle into the mix because I strongly believe that there's certainly a very solid space for selected cases of retinal detachment. And I will tell you how I have arrived to this conclusion. So the concept is not new. It's been explored for quite some time now. In 1952, Smith from Moorfields has proposed to use the air injection into suprachoroidal space and move the patient in such a way that the air will travel into the area under the brake and induce the adhesion by closing the brake. Later on, Strampelli in Italy proposed to use a gel into suprachoroidal space with a similar principle of inducing buccal effect. The idea was picked up a decade later by a German group who've used fibrin injection. So they've induced the first fibrinogen and then activated the fibrin and induced a clot, so essentially inducing suprachoroidal hemorrhage localized, and which will produce a buckling effect. And later, another group in Germany proposed using orbital fat into the suprachoroidal space to induce a buckling effect. So none of those have, of course, taken on, but the Ihab al-Rais I've lost the screen view here. Oh, yeah, there is. Ihab al-Rais later, so Poole and Sudarsky in 86 proposed using hyaluronic acid to induce similar buckling effect. The idea wasn't taken up until Ihab al-Rais, professor from Egypt, refined the technique and reintroduced it into clinical practice. And so he's been the promoter. But now there's quite a few groups in the across the world. Flavio Rezende in Canada, there's Peter German in Germany, and ourselves in the UK, which are using the technique quite widely and finding benefit. So these are the studies that, more recent case series studies that have showed a reasonably good success rate ranging from 92 to 100% in selected cases, and with fairly low complication rate. And I think the major explanation for the low complication rate is the technique, really. Using blunt cannula and very careful entry into suprachoroidal space is really the key. So this is why use suprachoroidal buckle? Well, it's induction of the scleral buckling effect, which we know has been shown to change the geometry of the buckling in such a way that the break is closed. But rather than inducing it with deforming the globe, we're using a temporary, highly viscous hyaluronic acid material, 2%, so Hyalon 5, which is licensed for use in the eye and available in most hospitals as a part of regular stock, certainly in our department. And the buckle stays there for about up to a week, which is sufficient to induce chororetinal adhesion, close the break, and then it dissolves and you don't see it. So there's no need to do extensive muscle slinging, opening up conjunctiva, and putting patient under anesthesia. So this can be done very quickly and localized under local anesthesia. So the instruments that we use are the straightforward blunt cannula, Hyalon 5. So Restylane has been proposed to use because potentially it has a more purified form and it's used in cosmetic surgery. However, it's not licensed for use in the eye, and in the UK we do not use it. So we use Hyalon 5, which has got the full license as a device in the eye. For the cannula, so the olive tip cannula certainly can be used, but we use just a very straightforward anterior segment tricored cannula, which has a small angle, and that angle is very beneficial because you can direct it towards the sclera. So as we enter the suprachoroidal space, we ensure that the angle of the cannula is facing the sclera. It's almost like scraping, following sort of scraping along the sclera. So that way, I know that it's not facing choroid and it's not going to puncture it as I advance into the suprachoroidal space. So the technique of the suprachoroidal buckle is quite simple. So we mark the break and do a localized peritomy of the sclera, conjunctiva, and then create an angled sclerotomy. The distance is usually 4 to 5 millimeters, but the most important thing is that to make the entry point convenient enough so that you don't, when we put it in and out under microscope, we don't have to sort of distort the globe too much. So it's easy access because we can travel within the suprachoroidal space quite comfortably. And also we're treating peripheral retinal breaks, which are usually in pre-equatorial area and easily accessible with just a small advancement. It's also quite nice to enter the suprachoroidal space slightly ahead of the break itself, because if there's any injury to the choroid, it's not under the break, it's a bit more advanced, it's a bit more forgiving, so you can still advance towards the break and preserve the suprachoroidal space per se. So here you see the we've placed the cannula, and now we're going to very slowly, under direct visualization, advance and inject and induce this nice buckling effect. And so the major advantage of that is that this, you can direct the cannula as convenient, and also you can judge by the height of the buckle as you need, so to position the break on top of the hill if you wish. So So just to summarize the advantages, it's minimally invasive, there's no intervention with muscles, there's reduced risk of problems with diplopia and motility, and it's done in a very controlled manner. You only inject as much or as little as you need, and it's temporary and it resolves with quick recovery following surgery as well. Of course, there are risks, like with any surgery. There's a risk of cutting too deep, cutting the vessels, creating retinal hemorrhage, choroidal hemorrhage. But because these are very anterior vessels, they're not the venous, they're not arterial vessels. If the choroid does bleed, then a little bit of pressure will stop the hemorrhage. So unless you go 3 and 9 and cut the long ciliary arteries, which of course then will produce a very rapid, strong, fast bleed. So here's a couple of examples. I think my screen is playing up a little bit, so I'm going to look at that. Yeah, so this is an example of a patient who presented to us during the COVID with bilateral retinal detachments. And he was the carer of his elderly mother, so we wanted to treat it in such a way that will preserve, will give him immediate recovery. And also the general anesthetic was a big problem during the COVID times. So we did a small suprachoroidal buckle in his left eye and just used a small bubble of air in the right eye. And he developed a quick recovery and without the need of using long-acting gases and positioning patients. So he was still independent and mobile and was able to continue his normal care and activities. So here's another patient that was, we wouldn't be able to put him to sleep because of the phobia. And he was also extremely nervous patient. So he had localized inferior detachment, and the fellow eye unfortunately had a retinal detachment repair with a big fold through the fovea. So it was basically a blind eye because he allowed the cataract to develop and occlude the eye because the diplopia from the fold was intolerable. So and with the just localized suprachoroidal buccal induction and the local anesthetic, we were able to achieve. So because in the interest of time, I will conclude my talk and just show that this procedure is safe if done carefully and improves the outcomes for the detachment with inferior breaks, and also can be used as a standalone procedure instead of scleral buckling. Certainly further studies are required, and we're currently running a Viking study which we'll be able to share the results with you hopefully in the next year. Thank you very much.
Yeah, in the interest of time, we continue with Alistair Laidlaw.